So today we are going to do continuation of the pathology. We already spoke about sialolithiasis, salivary gland tumors, and achalasia. Can somebody please remind me, in case of sialolithiasis, what should we do? How to treat it? Massage it, that's one, and induce saliva production. How can I do that? Sour candy. Absolutely correct. Nice. For salivary gland tumor, we spoke about multiple types of tumors. One of them had cartilage, which was which one? Had cartilage in it. The pleomorphic one. The pleomorphic is the only one that has cartilage. Okay. We spoke about achalasia, and I'm going to make here a shape in front of you, and I want you to tell me which one of these represents achalasia. So this is the lower esophageal sphincter tone, and here we have the following. So the first line is like this, like a flat line, imagine it. And the second one is like this. And the third one is like this. So what is number, so this is number 1, this is number 2, and this is number 3. Which one of these is achalasia? Number 2, it's achalasia. What does the word achalasia mean? What does chalasia mean? Chalasia means relaxation. Achalasia is failure of relaxation. So the lower esophageal sphincter will be constantly contracted, which means the lower esophageal sphincter tone will be high, okay? It will be high. What about the 3, guys? What is the 3? What is the 3? Yep, the peristalsis of the esophagus, which is a normal condition. And number 1, we did not study it yet, but please write a note about it. It's scleroderma. Okay, number 1 is scleroderma, in which we have totally absent contraction due to the fibrosis of the lower esophageal sphincter. Now let's continue speaking about the esophageal pathology. We have GERD, something I keep getting from drinking coffee. So first of all, let's start about the coffee. Why I keep get this heartburn every time I sip on my coffee? Why I keep getting it? What is the medical explanation for it? Well, excellent. There is inhibition of the phosphodiesterase in the smooth muscles in the lower esophageal sphincter, which lead to me exactly by the caffeine, which leads to relaxation of the lower esophageal sphincter, which lead to the gastric acid coming back into my esophagus. Can that be dangerous for the long term? Absolutely, yes. So it can lead to Barrett esophagus actually, which is a form of metaplasia. Okay, so what you will advise your patient who constantly have GERD after coffee? Yeah, that's possible, but look, in the US medicine, we like to go the cheapest way possible. I mean, if patient has asthma, you will not prescribe him salbutamol right away. The first line treatment is avoidance of the trigger. So you need, in case of patient having the problem from coffee, tell him stop the coffee. Go as cheap as possible. The first line therapy for hypertension, is it thiazide, ramipril, or weight loss and sport? Lifestyle modification basically. The answer is lifestyle modification, weight loss, and food. The same with diabetes, the same with hypertension. The same with disturbance of the menstrual cycle. Be really careful of this, because in the question of the exam they love these, because yeah, the sheeper they like the sheep options. Okay, so GERD commonly present with heartburn, regurgitation, and dysphagia. Okay, may also present with chronic cough and hoarseness. Well, somebody has GERD, he's having this heartburn all the time. So he start to take antacids, for example. Anyway, if somebody present to you to the emergency department with a heartburn, what you should do for him? The first thing you do. And he tells you that it's after food and it's related to food, which make you think definitely it's the esophagus. Excellent. You still must check the cardiac condition because you don't want him to have a typical myocardial infarction. So the first thing you check is ECG. Guys, can somebody have an MI without feeling any chest pain? Who? Who? Excellent. Diabetic patients have polyneuropathy, which means they don't feel anything, including the pain of an MI. So they write here, GERD commonly present as a heartburn, regurgitation, and dysphagia. May also be present as chronic cough, and the hoarseness, laryngopharyngeal reflex, is associated with asthma. It happens, the hoarseness most likely due to like the acid irritating the larynx, and the larynx has the vocal cord. Basically the larynx, it has another name, we call him, what do we call the larynx? Another name of larynx, we call him the sound box. Okay, it's associated with asthma. So yeah, it's associated with the asthma disease, and they have a transient loss of lower esophageal tone. So there is there is this common study that we can do by putting a balloon down to the lower esophageal sphincter, and we can check the tone of it. And according to the tone, we call it manometry, this test. So, and according to the tone, we can detect which disease the patient has. So let's take a look at this. So, see, this is the lower esophageal sphincter. But there is one that has the diseases. I hope I can find it. I cannot find it, so I will have to make you one. I just actually made it for you guys, and it looks something like this. So if the patient is going to have GERD, let's start with it like this. So this is the first line, and this is the second line. I'll just make it a little bit taller. Okay, so if the line was like this, which disease is it? Constantly contracting. Excellent, that's achalasia. What about this guy? Constantly relaxing. Scleroderma. And this guy, it is in the middle, he's contracting normally, and he's having like this peristalsis, but suddenly it drops like this, and then comes back to normal. What is this? This is GERD, okay? This is GERD. So they have normal peristalsis of their esophagus, but there is a constellation, an area in which their contraction is missed. Because of that, they have the symptoms of reflux of the acid. So if you look here, you can see also a few other things. For example, there is an eosinophilic esophagitis. The eosinophilic esophagitis, they love, in the sake of USMLE, to show you a photo of it. You will hear, so it's not in first aid. I cannot, let me check. Yeah, there is no photo in first aid. but they always show you this. Eosinophilic. Guys, it's eosinophilic esophagitis. Eosinophilic. So what do you think it's associated with? Eosinophilic. Eosinophiles. Eosinophils, so allergy, yeah? So it's actually an allergic reaction. Take a look how it looks. Like rings, 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 rings. Lord of the Rings. So here you go. So absolutely, yeah, the allergy. Allergy. Good. So the moment you see something like that, done. You have yourself a diagnosis. See how it looks like? This is eosinophilic esophagitis. Guys, if you take a biopsy of the wall, what you will see? You will see eosinophils. Can you see all of these pinker cells? These are eosinophils. So this area is full with eosinophils. You can see a few eosinophils here, a few of them here, a few of them there. Yep. Okay, so eosinophilic esophagitis, infiltration of eosinophils in the esophagus, often in atopic patient, which is like allergic patient. Etiology is multifactorial. Guys, what does it mean multifactorial? When I tell you a disease is multifactorial, hypertension is multifactorial, diabetes is multifactorial. Yeah, what is multifactorial? Asthma is multifactorial. Yeah, but actually you need to be more precise about it. Multifactorial means the disease we have both hereditary component plus environmental component. Okay? When we speak about hypertension, if my father had hypertension, I am at risk of hypertension. But if I live a healthy life, I will not get hypertension. That's multifactorial. So multifactorial means that you have both the hereditary and the environmental exposure. So be careful. There is also another word they can use for you, which means the same, which is polygenic disease. Okay, polygenic is the same as telling you multifactorial. So food allergies can lead to dysphagia, food impaction, and esophageal ring, and sometimes linear furrow can be seen on the endoscopy. So actually, to be fair with you, I always see in this picture, which is the ring formation. Sometimes they can have minor ulcers in the wall, but overall, it's the rings that give it away. Okay, so the next thing we have is, oh, by the way, how do you think we treat such disease? Let me give you the option. High dose steroid, low dose steroid. Tell the patient to stay away from the food that leads to this allergy. The third one, absolutely. It's an atopic condition, so probably they ate something, okay? So you tell them, don't eat that again. That's it. Okay. Esophagitis, which is an inflammation of the esophagus. We spoke about it. Do you remember where we spoke about it? Exactly in which disease? I told you we had the Candida esophagitis, we had the HSV esophagitis. Excellent, yes. We had the CMV esophagitis. It was an HIV patient. So, if somebody with HIV comes with you complaining of dysphagia, what is the first thing you are going to do? Option number 1, fluconazole. Option number 2, endoscopy. Option number 3, reassurance. Do not fall into this trap. You never give the endoscopy as the first treatment in an HIV patient. Why? Because you know that the most common cause overall is the Candida. So you must do like empirical therapy for a fluconazole, which is one pill only. If that helps, great. If it does not, you do the endoscopy. So in the endoscopy, you check. And if it was Candida, you will see the following. So Candida esophagitis, you will see this pseudomembrane. Actually, it's quite cool. Yep, So you can see all of these pseudomembranes all over the esophagus. While in case of HSV, you will be this volcano shape, if you remember, guys. The volcano shape esophagitis. So let's take a look at that volcano shape. Also, they like to call it a bunch out lesion. Yeah? So bunch out lesion or a volcano. This one. Okay. So the next one, it was in CMV. But what I want you to know here, guys, that it's a linear ulcer, and if we give the esophagus like this, is it going to be proximal or distal? The answer that CMV is going to be proximal. Okay? I'm going to ask you about this later, but the ulcer now, I'm telling you that the CMV will have the ulcer to be proximal. Why is this important? Because there is another disease that can lead to distal big ulcers, which look exactly the same. So let's take a look. There at CMV will have linear ulcers, and let's take a look at that. Oh, yeah. See this big one? All of this is the ulcer. Yes, I like this one. So yeah, all of this is the ulcer. That's CMV. Is the prevalence of CMV high in the community? Yep, it's really high. But okay. So if this is the mouth, and this is the esophagus, and this is the stomach, okay? The duodenum. This portion is the proximal esophagus. This portion is the distal esophagus, okay? Proximal means more proximal to the mouth, distal more distal to the mouth. Proximal portion is at high risk of CMV infection. Distal portion is at high risk of a disease called Mallory-West syndrome. Okay? Make sense? So, excellent. No problem. So, also caustic agent. Guys, do you notice chlorine we clean the toilet with? Yes, exactly. The patient will come to you and he will be like, mostly a baby or a child, little child who drank this chlorine, and that we consider that as caustic agent. Guys, if somebody drinks chlorine, should you make him vomit? No way, don't let him vomit. You will make it worse because it will burn while it's getting in and when it's getting out. Probably it will be mostly neutralized in the stomach, but yeah, you don't want it to go through the esophagus again. So you do just a gastric lavage and a lot of fluid. Okay, caustic ingestion or pill-induced esophagitis. Some of these medication, and all of them are in front of you, you need to be really careful when consuming them. They have some rules you need to follow. If you don't follow these rules, you are going to get pill-induced esophagitis or even like really bad dysgeusia, and really bad nausea and really bad GERD-like symptoms, including bisphosphonate. This bisphosphonate inhibit the osteoclast, which help in the building of the bone, especially in a patient with osteoporosis. Tetracycline, antibiotics, NSAIDs, iron, and potassium chloride. So, what is the correct way to take a medication that can lead to esophagitis? Take a look. Guys, you are future doctors. You need to know how to deal with this. First of all, you need to have the patient having the medication after food. This is step number 1. The second thing, big glass of water. And they should drink the whole thing. The third thing, and it's the most important, they should drink the medication while they are in the upright position, or even better, standing up. And after taking the medication, you tell them, stay standing up for 30 minutes. Do not lay down. Yes, because you want to make sure that the medication enter the stomach. Yes, so you wash it out with a big glass of water, and then you tell him to keep standing for 30 minutes, or like sitting upright. Okay, and for the iron, there is something special. And instead of consuming it every day, we prescribe it 3 times per week. So that will be Monday, Wednesday, and Saturday. Okay, different from one resource to another, but in general, 3 times per week. Esophageal stretcher. Oh, before esophageal stretcher. See, this is the candida, the pseudomembrane. And the next one is esophageal stretcher. It's associated with the cosmetic ingestion, like what I told you about it. What can lead to cosmetic ingestion injury? Absolutely, yes. The chlorine, this guy. Yep. So who will be the person who consume it? A child, always. Okay. So, yeah, and acid reflux and esophagitis, all of these can lead to esophageal stricture. Esophageal stricture are no fun. I want you to make a small note next to them. They can be converted into squamous cell carcinoma. So, the esophageal stricture are a serious condition. It's no joke. Yes, they can lead to dysphagia. Yes, they can lead to dysphagia. What do you think, guys? Is the dysphagia going to be to the solid or to the liquid? No. In the beginning, it will be only... Oh, yes. So if you take a look here, can you see? This is the stretcher. It's not covering the whole thing. So it will be only solid. What can you do about it? In the real life, we like to put a balloon inside and inflate, deflate, inflate, deflate. You will have what? You will have a better opening. Yes? So this is the esophageal stretcher. Okay. So it can lead to what? Squamous cell carcinoma. Make a note about this. Make sure you know it. The next one is Plummer-Vinson syndrome. The patient is going to have this triad: dysphagia, iron deficiency anemia, and esophageal whips. So the iron this patient will have these 3 symptoms, but what I want you to know is about the iron deficiency anemia. What will happen to the CMV in case of a patient with iron deficiency anemia, CMV? Yes, the CMV is going to be low. And they can have the esophageal whip, so they also can have what? Dysphagia to solid or liquid? Solid. Increased risk of also squamous cell carcinoma may be associated with the glossitis. For a Plummer-Vinson syndrome, I would like you to understand what is an esophageal whip. You're like, yeah, it's like a stretcher. Not exactly. So if you take a look at the whip, yes, wait a second, bad picture, better picture. All of the walls of the esophagus will be penetrating to this side. It's not just the membrane, it's the actual wall of the esophagus, okay? And both of the esophageal whip and the stretcher can be due to, just a second, can cause what? Can cause squamous cell carcinoma. So here you go. Okay. So Plummer-Vinson syndrome, the patient will have a triad of dysphagia, iron deficiency anemia, and esophageal whip. And the manner Weiss syndrome. Let me tell you actually the story about this. It's a lady that induces vomiting. What do we call these patients when they induce vomiting? Yes, bulimic, but here is the thing. To give a diagnosis of bulimia or anorexia nervosa, the only thing that differentiates between the two is the weight. I mean, if the BMI is less than 18, the patient becomes automatically anorexic. But if it is more than 18, the BMI, of course, the patient becomes automatically bulimic. Okay, so we have the Mallory-Weiss, partial thickness, and longitudinal ulcer of the gastroesophageal junction. How did we call a linear longitudinal ulcer of the proximal esophagus? It had another name. CMV. Absolutely. So it's confined to the mucosa and submucosa. If the ulcer only affected the mucosa, it's not an ulcer. It becomes a erosion. Okay? If it is only affecting the mucosa, we call it erosion. If it's affecting both, we call it an ulcer. Due to severe vomiting, often present with hematoemesis, abdominal and back pain, usually found in patients with an alcohol use disorder and bulimia nervosa. Okay, nice. So either alcohol use disorder. Why the alcohol use disorder? Because these patients retch, do the process of retching. I hope you know what is retching. It's when someone vomits, but he keeps inducing vomiting, forcing himself to vomit more. So that can lead to ulceration of the lower portion of the esophagus, which can lead to Mallory-Weiss syndrome. And also because of bulimia nervosa, we established that. What is the cutoff between bulimia nervosa and anorexia nervosa? I mean the BMI cutoff. Correct, it's 18. So the next thing we have here is about esophageal varices. Interesting. So it can be due to a dilated submucosal veins. It will be in the last third of the esophagus due to portal hypertension. So it can lead to cirrhosis and maybe a source of life-threatening hematoemesis. Make a note. BMI range. Yes, absolutely. So this is actually a psychiatry question, but if we have an anorexia nervosa patient versus bulimia nervosa. So they tell you the patient vomits, like she's inducing vomiting and all of that. So you know it's one of them, but you cannot tell. You need to look at the BMI, you know? So if the BMI was if the BMI was less than 18, it's anorexia nervosa. If it was more than 18, it's bulimia nervosa. I hope it makes sense. So more than 18, bulimia nervosa, less than 18, anorexia nervosa. These anorexic patients also have something called the Russell sign, okay? Yes, they have this something called Russell sign. They have this on their hand. Why do you think they have this on their hand? Basically, when they put their hand in their mouth to vomit, absolutely. When they put their hand in their mouth to vomit, they traumatize their knuckles, which is a positive sign, okay? So you will look at her hand or his hand and you can tell if they do such thing. Okay. Also, maybe you will learn in forensic medicine, when you have a hand of the patient, how can you tell if he had previously tried to commit suicide? You can look at his vein, okay? And if the vein are appearing, and then suddenly disappear, and then appear, but at a lower limit, that means she previously cut her hands, okay? Okay, so, okay, let's take a look. The next thing we have is the esophageal varices. I want you to know a few points about this. Except the esophageal varices, portal hypertension can lead to what other? Portocaval syndrome. What other portocaval connection do you know? The caput medusa, that's one. What else? The internal hemorrhoid, absolutely. They will not be painful. Okay, can we treat esophageal varices or the patient is screwed if he gets them? It's deadly, but it's treatable. That's important. It's basically really, really treatable. So let me give you a quick look about how do we treat them. So basically in this patient, oh, neat. Okay. So take a look, guys. We are not in business. I don't know how to delete that. Well, basically in the beginning, you can do a balloon tamponade to stop the bleeding acutely. As you can see, you can insert a balloon into the stomach, and by inserting this balloon, it's going to stop the bleeding. Also, you can do an endoscopic sclerotherapy in which you inject the ethanol aloate, which is a solution that burns the vessels. And finally, you can put a band. And this band is done by, see, can you see the rubber band here? So you put the scope, you put it around the varicose vein, and you release the band on it, which you clamp it off. The last thing, when nothing works, you can do the TIPS procedure, in which is a connection between the portal vein and the hepatic vein. That's it. Okay, so let's go back to first aid. We have the next topic. It's about distal esophageal spasm. Oh, distal esophageal spasm, the patient is going to have something like this. Formerly was used to being called diffuse esophageal spasm. Okay, it's a spontaneous, non-peristaltic, uncoordinated contraction of the esophagus with a normal lower esophageal pressure. So, the problem with this patient, he will be like this. On the tonometry, he will be like normal peristalsis, and suddenly do something like this. He contract and does not relax. Okay? So that we call it a distal esophageal spasm. So it presents with dysphagia and an angina-like chest pain. Quite famous actually. And on the barium swallow, you can see this corkscrew esophagus, but sadly it's difficult to catch. Why? Because this occurs like spontaneously. It does not occur all the time. Okay? So let's take a look at it. Yep. Oh, I hope you can see the corkscrew of shape of the esophagus. If you see that, it means that the esophagus is at the state of contracting. But the problem is that he's not contracting everywhere. So some portion is contracting, some portion is not. That means that it's going to, if you put the barium, some area will be contracting, some area are not. It leads to really sharp chest pain, guys. That makes the patient is like, doctor, it's horribly painful. I'm having a heart attack. He's not having a heart attack. It's an esophageal spasm. So you can do manometry to diagnose it, and the treatment can be with nitrates and calcium channel blocker. Does anybody know why nitrates and calcium channel blocker? What does these two drugs have in common? They are both smooth muscles relaxers. So the next one is about scleroderma, esophageal involvement. Let me draw for you a couple of structure. Again, the manometry thing. We have something like this. This is picture 1. This is picture 2. This is picture 3. Which one is the scleroderma? Let me put the number again. The flat line down here is 1. The upper line right there is 2. And the third one is a 3. Absolutely, it's number 1, scleroderma. What about number 2? What is number 2? The GIRT, absolutely. Number 3, normal person. Now I will make something tricky. Let's take a look at this. So there is something like this. Wait a second. Somebody, we did a mistake, but I did not recognize it. The constant contraction here, this is achalasia. Okay? So this is achalasia. But when we speak about this is a normal person. When we speak about a person like this, and suddenly do something like this, and then do like this. This is what? GIT, okay? But if we have a patient like this, and then do something like this, this is diffuse esophageal spasm, okay? So scleroderma, esophageal smooth muscles, atrophy leading to decrease in the lower esophageal sphincter pressure and distal esophageal dysmotility. So the patient is going to have acid reflux and dysphagia, which can precipitate to stricture formation, embarrassed esophagus, and even aspiration. It's part of the CREST syndrome. Let's take a look at the CREST. What does the C stands for? Calcinosis and... Anybody know what is the CREST stands for? Calcinosis and anti-centromere antibody. The R, Raynaud phenomena. The E, esophageal dysmotility. The S, sclerodactyly. And the T, telangiectasia. Okay? So, the esophageal dysmotility is the what? Is the complete relaxation of the lower esophageal sphincter due to the fibrosis and the atrophy of the smooth muscles. The last one is esophageal perforation. The most commonly iatrogenic following an esophageal instrumentation. You put the esophageal tube and you accidentally burst it. And if we look at this patient, they are going to have air inside of their mediastinum. Remember, the mediastinum was the area between the two lungs, yeah? So non-iatrogenic cause can be due to spontaneous rupture, foreign body ingestion, trauma, or even malignancy. So may present with pneumonia mediastinum, which is something they would like you to recognize, and I will show it to you in a second. So let's actually take a look at it right away. So there will be air inside of the chest cavity. Okay, and it will look black because air is black, yeah? So you can see there is air in the mediastinum. They like to do a CT of it actually, but I hope you can see the seeping air, the black thing here around the heart, yeah? This is inside of the mediastinum. Nice, even better. Even you can see it here. You can see it here. You can see it in the creases here. And you can see it here. Okay, so also they can have subcutaneous emphysema. And if you guys push on it, you will feel crepitus. What does it mean, crepitus? Well, can somebody describe for me how does the crepitus feel? Yeah, it's because of the gas. If you remember when we spoke about which bacteria also it led to crepitus, because of inflammation of the skin and it produces the gas. It was Clostridium perfringens, absolutely. Good. So they can lead to the crepitus. The more you push, you will be hearing like something like that. So crepitus in the neck region or chest wall. So this patient can have also Borhav syndrome, which is due to a transmural, usually distal esophageal rupture due to violent retching. This retching also led to something else. Do you remember, guys, what was it? Right, the initial stuff. The Mallory-West syndrome. So Mallory-Weiss syndrome was just an ulcer of the mucosa and the submucosa. If it keeps going and affects the muscularis and the serosa and rupture the whole esophagus, it becomes Boerhaave phenomena. Okay? So a patient with Mallory-Weiss can be complicated with esophageal perforation. That's why you want to catch it early. Okay, guys. So we'll have now a 10 minutes break. We'll come back. We'll speak about Barrett esophagus, cancers of the esophagus, gastritis, Menteriae disease, gastric cancer, and peptic ulcer disease, and ulcer complication and acute gastrointestinal bleeding. So see you guys after the break. Now we are going to speak about my dear friend, Barrett esophagus. So when we speak about Barrett esophagus, this is a form of cellular adaptation, guys, in which the esophagus is trying to adapt for the constant exposure of the acid to him, which can occur during the state of GERD. Okay? So these patients have the following disorder. Barrett esophagus, it is basically the type of the epithelium that normally exists in the esophagus is going to be changed in the type of epithelium that is normally exists inside of the intestine to be able to handle the stress of the acid. So there are the specialized intestinal metaplasia, as the arrow show here. Well, to be fair with you guys, you cannot see anything here. You can just see an area that is pink and an area that is red. That's it. So this reddish area represents the metaplasia. So there will be replacement of the normal type of epithelium inside of the esophagus, which if you don't know, you can check the file that I sent once named circulatory. And it's written all of the types of epithelium that exist in the body there. So there will be replacement of the non-keratinized stratified squamous epithelium. Guys, why do you think the esophageal epithelium has so many layers? To be able to handle the trauma from the food. Yes, exactly. Excellent. So it will be converted into the intestinal epithelium, which is a non-ciliated columnar epithelium with goblet cells. The goblet cells' function is to secrete a mucus. And all of this process will happen in the distal esophagus. Guys, what is this whitish cell here? We call this goblet cells, absolutely, and it secretes mucus. If you take a look here, you cannot see anything, but let me show you what you actually need to learn. Barrett esophagus histology. So when you take a look at the Barrett esophagus histology, it mostly happens at the junction between the esophagus and the stomach. So how do I know that this is the esophagus? Because it has a stratified layer, so many layers over each other. Well, the stomach has these crypts, yeah? And this patient, if you notice, his crypts now contains goblet cells, which is highly abnormal. For either, the stomach does not have goblet cells, the esophagus doesn't have goblet cells, but now we have goblet cells. So this is an intestinal metaplasia, yes? Which is the same type of epithelium inside of the intestine. Okay. So the next thing they speak about, due to chronic GERD, and it's associated with increased risk of esophageal adenocarcinoma. A little bit later, I will be telling you that the lower 1/3 of the esophagus will have adenocarcinoma, while the upper 2/3 are going to have squamous cell carcinoma. And before I go to that moment, I want your help with something. Can somebody tell me, please, in the patient who have which disease they also can develop GERD? Something we just spoke about in the page before. Yeah, eosinophilic esophagitis, that is possible. Scleroderma, they can have some reflux, that's possible. So many diseases basically can lead to it. So it's not solely the GERD thing. Basically, it's multifactorial. There is many reasons that can lead to it. And if we speak about, can somebody give me another example of metaplasia? What another example of metaplasia do you know? I will give you a minute to think about one. Well, you can think about metaplasia as the conversion of one type of cell to another type of cell. One really common example is when the people smoke. So when they are going to smoke, they are going to change their respiratory epithelium into squamous cells. Okay? So smoking convert the respiratory epithelium, which is a pseudostratified columnar epithelium, into a squamous epithelium. Okay? So we have now the following. Esophageal cancer typically presents with a progressive dysphagia, which is in the beginning for the liquid. Why it's a progressive? Because if the mass inside of the esophagus looks like this, the water can still go through, but the big chunk of food cannot. But eventually, when the cancer gets bigger, also water will have a problem, yeah? So these patients are going to have a problem with the swallowing of the solids and then the liquid and weight loss. Aggressive course due to lack of serosa in the esophageal wall, which allowing the rapid extension. So when the esophageal wall doesn't have the serosa, that means the cancer can leave the esophagus and affect the nearby organ, including the mediastinum. Poor prognosis due to advanced disease at the presentation. So basically we discovered it too late. Now we are going to speak about squamous cell carcinoma and adenocarcinoma. Some countries like Iran and other countries in the Middle East, people like to drink hot tea, but they drink it hot. So the tea will be hot. Why this is important? Well, if you keep drinking hot tea, is that erosive for your esophagus? Yes or no? Logically. Absolutely, it will be really erosive to your stomach. But wait a second, not your stomach. What is the first portion to be exposed to this really hot liquid? Is it the upper esophagus or the lower esophagus? The upper esophagus, absolutely. What about alcohol? Also, the first area to be exposed is the upper esophagus. The same with this, smoking is a bastard, but speak about it in a second. So look what they write. Squamous cell carcinoma can occur due to alcohol, hot liquids, caustic agent, caustic stretcher that basically are due to caustic agent like a chlorine, smoking as well, and achalasia. Many countries in the Middle East, people like to drink hot water, especially on a hot day. You are like, seriously, are they stupid or something? No, it's actually really useful. So basically, I've seen this in real life. When you go visit somebody in like the desert, they will propose for you a really hot tea. It's sign of disrespect if you don't drink it, so you drink it. And you will realize after you drink it, it's really hot, the weather, but you suddenly become more cooler. Why? Because by increasing the inner temperature of your body, your skin becomes much cooler. So you feel more cool. Okay? So that's why they do it. It's really common worldwide, the squamous cell carcinoma. And if you do histology, what you will see in case of squamous cell carcinoma. Hint, all of the squamous cells, doesn't matter the location, all will have the same thing. This structure, the keratin barrels. The keratin barrels. If the lady has a cervical squamous cell carcinoma, head and neck squamous cell carcinoma, esophageal squamous cell carcinoma, lung squamous cell carcinoma. All of these will have the exact same thing. Okay, so the adenocarcinoma, on the other hand, is going to affect the lower 1/3 of the esophagus, and it's due to chronic GERD, Barrett esophagus, also obesity. Why? Because increased intracranial, because increased intra-abdominal pressure promote to GERD, which can lead to adenocarcinoma. Also, tobacco smoking, and it's more common in the U.S. because the basically it's biostat. It's the epidemiology and the relevance of the obesity in the US is much more higher. Okay, gastritis, which is inflammation of the stomach. So the gastritis, we have the acute one and we have the chronic one. Each one of these is important individually. You will see it in real life. You will see it on the exam. So erosions can be caused by the following. So, in case of erosions, which layer are damaged, guys? Do you remember which layers will be damaged in case of the erosion? The mucosa and the submucosa. What about submucosa? Is it damaged? Nope. That is no. If the submucosa will be affected, the name changes to ulcer. Okay. So for now, it's only the mucosa. So NSAIDs normally. So forget about NSAIDs. Our gastric mucosa is normally protected by prostaglandins E2. So when you use an NSAID, they will decrease the prostaglandins E2. Remember, for the sake of making the prostaglandins E2, there is something called arachidonic acid, which gets converted into the prostaglandins. And this procedure is mediated by an enzyme called COX. So the NSAIDs inhibit the COX, which decreases the prostaglandins, which decreases the protection of the stomach. Okay? That's why NSAIDs can lead to acute gastritis. The next one is actually quite important, which is the curling ulcer. So the curling ulcer, it happens due to burns, and basically when we get burned, we get a lot of blisters. We lose a humongous amount of fluid from our body. So basically, if we lose a lot of water from our body, let's take a look at this. This is the stomach, yeah? And it has its own blood supply and stuff like that, but let's take this small area for a second. The blood supply comes from the outside to the inside, yes? So if I'm going to show you the wall of the stomach only, like this, the blood vessel is going to be here, and it's going to penetrate the stomach like this. So if somebody gets a really humongous hypovolemia, will there be decreased perfusion to area 1 or area 2? Where the perfusion is going to reduce more in case of hypovolemia? Remember, this is a blood vessel. Area 2. Because area 2 is basically a water shed area. Yes, watershed area. So when the blood, somebody gets a burn, for example, he loses a humongous amount, this area of the stomach is going to get really low in perfusion, which basically leads to an ulcer. Yeah? So the next one is a brain injury. In case of a brain injury, there will be increase in the intracranial pressure, which increases the vagal stimulation and thus increases the acetylcholine. And more acetylcholine mean more parasympathetic nervous system activity and more hydrogen production, which lead to an ulcer. So especially common among patients with alcohol use disorder and those who take daily NSAIDs, like for rheumatoid arthritis. They love to mention for you somebody who's like in a chronic analgesic use. Like for example, he has like gout or something like that, and he takes the medication every single day. And you need to start suspecting that is the cause of the ulcer. It's really common in real life actually. So chronic gastritis, on the other hand, the patient can have this mucosal inflammation, often leading to atrophy, like hypochlorhydria and hypergastrinemia. What is the other disease I told you about in which the patient had hypochlorhydria? Or achlorhydria, to be more exact. I hope you are thinking about the VI BOMA. VI BOMA. VI BOMA had Wadhal syndrome, WDHA, watery diarrhea, hypokalemia, and achlorhydria. So the hypochlorhydria basically means reduction of the hydrochloric acid in the stomach, which can lead to hypergastrinemia as a feedback mechanism, and also intestinal metaplasia, which increases the risk of gastric cancers. Okay, of course we are speaking about intestinal metaplasia of the stomach, yes? So the stomach becomes looking like the intestine. So there is two types. There is type A and there is type B. Type A is autoimmune. Type B is bacterial. Okay? So the autoimmune type, let's start with it actually. Autoantibody against the hydrogen potassium ATPase on the parietal cells and to the intrinsic factor. There will be an increased risk of pernicious anemia, which is is it a microcytic or a macrocytic anemia? Macrocytic anemia, yes, which mostly affect the body or the fundus of the stomach. The H. pylori, on the other hand, is the most common, increase the risk of peptic ulcer and multiple lymphoma. Guys, is cancer reversible or irreversible? Somebody has like a neoplasia. Is it reversible or not? So generally is not reversible, okay? But this is the only case in the USMLE that you have to know that the cancer is reversible by treating the initiator cause, which is the H. pylori. If you treat H. pylori, the mouth lymphoma will go away. It mostly affects the antrum first and spread the body of the stomach. So it mostly affects the antrum. Why the antrum? Pylori. The pylorus is located in the antrum of the stomach. Yes? While the parietal cells are located at the body and the fundus of the stomach. Good. Nice. So let's now take 5 minutes break, and I will see you guys after the break. See you in 5. Hello everyone, welcome back. So let's take a look. So we have something called Menterier disease, which is due to hyperplasia of the gastric mucosa. Is hyperplasia increase in number or increase in size? It's increase in size, okay? And sorry, increase in number. Hyperplasia is increase in number. Hypertrophy is increase in size. So, Menterier disease is a hyperplasia of the gastric mucosa, which will lead to hypertrophied rogae. What is a rogae? Well, inside of our stomach, we have this dentation, basically. Stomach, rogae. So, it's basically all of this dentation, as you can see, the going up and down on the mucosa. This we call a rogae, okay? So there will be hypertrophy of the gastric rogae, and they are so hypertrophied, they look like gyri of the brain. Yes, they look like a brain, and it causes excess mucus production that result with the resultant protein loss. Guys, the mucus itself that is produced contain inside of it proteins. So if you are going to lose a lot of proteins, you are going to get what? What happens to the person who loses a lot of protein? Think about nephrotic syndrome. You are going to get what will happen to your oncotic pressure? Well, yes, absolutely. So your oncotic pressure is going to go down, which precipitate you to getting an edema. Yes. So these patients are going to have weight loss, obviously, anorexia, vomiting, and epigastric pain. There is a brain inside of their stomach. And edema because of the protein loss, which can lead to decrease in oncotic pressure, leading to the edema. Now we speak about the gastric cancer, stomach cancer. So it's most commonly due to gastric adenocarcinoma. It can be a lymphoma, GI stromal tumor, or carcinoid. So many causes, but adenocarcinoma is the most important. It has an early aggressive local spread with lymph node or liver metastasis. Why gastric cancer like the liver? Because of which circulation? Simply because of the portal vein. Okay, so, well, like any other cancer, they will have the weight loss, the abdominal pain, early satiety. Why? Because the stomach is having a full mass in it. And also it is associated with acanthosis nigricans. Let's take a look at that. So acanthosis nigricans, do not be tricked about this, guys. When you see this in a patient, what you should think about? What is the number one thing you think about when you see acanthosis nigricans? The answer is diabetes mellitus, absolutely. But in which case you would think that it is a cancer? It is when it happens really, really rapidly. I mean, the patient gets all of this in a matter of like days, okay? If he tells you, oh, this just appeared previous week, you are thinking, okay, this is cancer. But if he tells you, yeah, it's been there for 6 years, you are like, no, it's diabetes. Also, the lesser it relate. So there is something called sebatic keratosis, which looks like this basically. If you only have one of them, this is completely normal. But if you have so many of them that occurred like within a week or really, really quick, this is a sign of cancer. We call it a lacerate relate. Remember, it's a seborrheic keratosis. Yeah? We have two types of gastric cancer. So the first one is called the intestinal type, which is associated with H. pylori and dietary nitrosamines, the smoked food. In which country we have a lot of smoked food, guys? Yes, Japan and some areas of the US, especially the Midwest. And we have here tobacco smoking, achlorhydria as well, and chronic gastritis, okay? It's commonly affect the lesser curvature, and it looks like an ulcer, but the margins will be up like this, okay? Rubbed. Yeah, they will be just raised up margins. Guys, anytime you face a gastric mucosa, when you do an endoscopy, what you should do, any gastric mucosa. Well, if you have a gastric, anytime you go inside and you see a gastric ulcer, you must biopsy it. But if it was a duodenal ulcer or a small intestine ulcer, you should not biopsy it. Why? Gastric ulcer can be malignant. Small intestine ulcer cannot be malignant, okay? Thus, for the gastric one, you must do a biopsy. For the duodenal, no biopsy. So, Intestinal. So we spoke about all of these. We spoke it's the lesser curvature and it has the raised margins. The diffuse one, however, it's not associated with H. pylori. It's, in the other hand, associated with something else, which is basically like hereditary diseases, the tumor oncogene, the tumor suppressor gene, this type of thing. So the most cause is due to E. cadherin mutation. It can lead to signet cell formation, which is a mucin filled cells, and it looks like a ring. I hope you can see this ring. It's something like this, yeah? It looks like a ring. So this is the signet ring shape. There is something I want to explain for you that what is E. cadherin. If we draw here an epithelial cells, between epithelial cells, what keep the epithelial cells tied together? Does anybody know how the epithelial cells are bound to each other? The answer is E. cadherin. So the E. cadherin keeps them bound together. So for the sake of a cancer cell, let's say this is a cancer cell, and she want to go down here. It must downregulate the E. cadherin. That's the first step. The next step is to produce something called collagenase. Yeah? To destroy what? To destroy the type 4 collagen in the basement membrane. And the last step is to bind to something called fibrinolactin. So, 3 steps for cancer spread. 1. Downregulation of E. cadherin, so we will have less attachment between the epithelial cells. Yeah? Step number 2. What was step number 2, guys? Somebody tell me, what was step number 2? Yes, destroy the collagen type 4 in the basement membrane so the cancer cells can make it to the interstitium. The last step is to bind to something. Bind to what? Exactly. Bind to the fibrinolactin and something called laminin. Okay? And step number 4, go to blood if you are a sarcoma, or lymph if you are a carcinoma. But there was an exception for carcinoma. Remember, hepatocellular carcinoma, renal cell carcinoma, choriocarcinoma, and follicular thyroid cancer. These 3 go to blood, not to lymph. Okay? So, look what they write. Diffuse cancer is not associated with H. pylori. The most common cause is due to E. cadherin mutation. So, the signet ring cells, will be a mucin-filled cells with a peripheral nuclei. They look like a ring. So this something like this. And the stomach wall becomes really thick. It's the diffuse type, so that it becomes really thick and leathery. So we call it linitis blastica, in which I don't know, guys, like especially ladies will understand me here. The bags of the lady that are made out of leather, they are quite thick. The same with the stomach. The wall of the stomach will be super thick. It will be like a plastic. Okay, so the Purgoff node, it's it's located the left supraclavicular lymph node. So left supraclavicular lymph node, and anytime it's enlarged, you need to suspect visceral cancer, especially gastric cancer. It does not go to the right one, because the right one, right abdominal cavity organs will be mostly going, like, it will be obstructed by the liver. Also, remember, if we speak about the thoracic duct, it empties to the left subclavian, not the right subclavian. So, it involves involvement of the left supraclavicular node by metastasis from the stomach. Next, we have something called the Krukenberg tumor, which is a metastasis to the ovaries, typically bilateral, abundant mucin secreting signet cells. So if you biopsy these ovaries, they will also have signet cells. That means that the Krukenberg tumor, is it due to the intestinal or diffuse type of gastric cancer? Come on, somebody write me, is it intestinal or diffuse? It has signet cells. So the answer, since it has signet cells, yes, it must be diffuse. So a really common question actually on the USMLE. They like to show you a picture. They give you a picture of the stomach and a picture of the ovaries. And they are like, well, what happened? And you can see even the signet cells here. They are like, what happened? This is a Krukenberg tumor. Krukenberg tumor. You can see the signet cells here. Okay. So yeah, you can see a picture of the stomach, picture of the ovaries, and they ask you what's up. It's a Krukenberg type of metastasis. Sister Mary Joseph notes, this is lady that discovered like patient who had like gastric cancer. Before they die, all of them have this thing in their umbilicus. And she noticed that, and she told the doctor, and the doctor wrote a paper about it. And it was known by her name after that. For the USMLE, they would like you to know the CT and how it looks like. And if you take a look at this CT, you can see the mass in the umbilicus. Okay. Blummer shelf. So palpable mass in the digital rectal exam suggesting metastasis to the rectouterine pouch. So the rectouterine pouch, how can we palpate it, guys? How do you think you can palpate the rectouterine pouch? Which test you will do to the patient to check it? So for the sake, absolutely, digital rectal exam. So the pouch of Douglas is for a lady like the prostate, okay, in men. So the pouch of Douglas is located at the exam same place as prostate in a man. So you have to do digital rectal exam to be able to palpate it. Okay. So now we speak about the peptic ulcer disease. Guys, let me tell you a story. They will give you a question about a man who consumes jalapeno, a lot of spices. He eats taco with jalapeno. He eats a lot of spices. On the breakfast, he eats jalapeno. On the lunch, he eats some other type of pepper. At the dinner, he eats a lot of chili. And after that, he developed ulcer. What is the cause of his ulcer? 1, H. pylori. 2, NSAIDs. He takes NSAIDs as well. 3, the spicy food. What do you think? What is the cause of his ulcer? So again, the history, he eats a lot of spicy food every single day, breakfast, lunch, and dinner. And he is taking NSAIDs also. This is the tricky question. It doesn't matter how much stuff they tell you, it's always the H. pylori, guys. If they keep telling you from today until 6 days from now that the patient is eating spicy food and there's one answer that says H. pylori, choose that, okay? Why the H. pylori? Because it's the most common cause overall. It's a tricky question. So if you take a look here, you can see the gastric ulcer and the duodenal ulcer. So the pain in the gastric ulcer, it may be greater with meals, yeah? Why it's greater with meals? Because there will be more acid secretion during the meal. Yes, so that leads to weight gain. H. pylori infection will be the 70% of the time, which is most of the time. Yes, that's why it's the correct answer. The mechanism is decreased mucosal protection against the gastric acid. If you remember, I even told you guys, like this H. pylori will get into the mucosa, hide under the mucosa, and then will start use its urease to make an alkaline environment. Yeah. So the Parietal cells will start secreting extra acid, which will lead to the ulcer, while the H. pylori is hiding. Other causes include NSAIDs, and the risk of cancer is high. That's why we must biopsy every single cancer we find in the stomach. So biopsy margin to rule out the malignancy. The duodenal one, on the other hand, they decrease the pain with meals, and they can lead to weight gain because the patient keeps eating not to have the pain. So let's try to think why they have the pain when they are fasting. Because when you start fasting, the stomach, you will have this abdominal cramps basically, yes? So your peristalsis is going to start and until the moment you eat. The moment you start eating, the food will go where? Into your stomach. When the food is in your stomach, you will have release of a lot of gastric acid on it in the stomach. So it's not touched yet. So at that moment, the secretin will be low. When the secretin is low, the stomach will be turned on and the duodenum will be turned off. No pain. So as long as you are eating, the duodenum is off, no pain. If you stop eating, the food will move to the duodenum, which lead you to have pain. So it's 90% of the patient are due to H. pylori, so it's the most common cause. Decreased mucosal protection and also increased acid secretion. Zollinger-Ellison syndrome, which is, does anybody remember what is Zollinger-Ellison syndrome? I told you about it yesterday. It was a cancer that can lead to production of something. Gastrin, absolutely. So it leads to hyperproduction of the gastrin, and which can increase the HCl, which can lead to the duodenal ulcer. So this is generally benign. So benign appearing ulcer and not really routinely biopsies, because most likely they will be totally benign and they will not lead to any problem. So when we speak about the ulcer complication, there is gastric ulcer, we have the duodenal ulcer. Remember, if I draw a duodenum here, is the blood supply, I mean the blood vessel, is it posterior to the duodenum or anterior to the duodenum? The gastroduodenal artery, I mean. It's posterior to the duodenum. So will it be in the anterior duodenum ulcer or the posterior duodenal ulcer? We will have hemorrhage. Posterior duodenal ulcer, exactly. So gastric, duodenal, so the hemorrhage can be in both gastric and duodenal, posterior more than anterior. Most common complication. Rupture gastric ulcer on the lesser curvature of the stomach will lead to a bleeding from the left gastric artery. Yes? So the left gastric artery is going to bleed, and that's only if it affects the lesser curvature of the stomach. Okay, what about if it is affecting the posterior wall of the duodenum? That will be I told you if the duodenum was here, there was something called the gastroduodenal artery, which run posterior to the duodenum. Come on, yes. So you can see this picture, and you can see here the gastroduodenal artery running posterior to the duodenum. Yep. So the next thing is, guys, if the penetration of, so this is the duodenum. If the ulcer was posterior, we are going to have hemorrhage. But if it is anterior, air from the duodenum, the air are going to go out, which is going to lead to perforation basically. Yeah? So before I speak about perforation, let's speak about obstruction really quick. When basically there will be a type of healing that might lead to pyloric channel obstruction or duodenal obstruction because of the healing. Finally, the perforation, it's mostly going to be anterior because there is no blood supply here, so there will be no hemorrhage. So the anterior duodenal ulcer can perforate into the anterior abdominal cavity, which potentially lead to pneumoperitoneum. If you see a pneumoperitoneum, what can you explain? No pain. No pain. There is pain, but the pain is on fasting. Okay? So when you are fasting, yes, you are not eating anything, will you have high or low gastric acid? Yeah, well, relatively low. So the gastric acid is going to be low. So at that moment, let's say that you started to eat. I'm eating, so there will be more food inside of my stomach. There will be more acid at that moment, yes? So more acid in the stomach. So in the stomach, when the stomach is active, what happens to the duodenum? When the secretin level is low. Remember, there was a secretin hormone, which is produced by the S cells, yeah? It normally stimulate the stomach. I'm sorry. It normally, what does the secretin does? Can somebody remind me? Yes. So basically, there will be in case if you ingest the food, there will be less secretin. That means stomach works more, duodenum works less. If the duodenum works less, that means that there will be less pancreatic juice secretion. So if you have less pancreatic juice secretion after the ingestion, immediately after the ingestion, of course, not after some time, immediately after the ingestion, less pancreatic juice secretion to give the stomach some time to deal with the food inside of it. So during this phase, you have less pancreatic juice secretion. The pain is going to be reduced, okay? Until after some hours after the food will move to the duodenum, which will lead to pain. So the pain will mostly occur in a late fashion, okay? So mostly they say, oh, it's during, like when we don't eat, but if I eat right now, the pain will go away. Absolutely, because the pain will, there will be less pancreatic acid secretion, sorry, not acid, pancreatic juice secretion, which will lead to less pain. So you might see, in case of the perforation, air under the diaphragm, which lead to pneumoperitoneum, with referred pain to the shoulder via irritation of the phrenic nerve. Does anybody know what is phrenic stands for in the word phrenic nerve? Welcome. Phrenic nerve. What does phrenic nerve mean? Phrenic nerve means diaphragm, okay? And that's phrenic nerve can be stimulated not only by gastric ulcer, actually multiple things. So you can see here the phrenic nerve, it's going here and then it's going up. It can be stimulated in case of cholecystitis, inflammation of the gallbladder, leading to right shoulder pain, gastritis or gastric ulcer, left shoulder pain, okay? So it's according to what stimulates it, the patient is going to have the shoulder pain, okay? So yeah, that's phrenic nerve. And the next thing is going to be, if you see anytime a pneumoperitoneum, this is an indication for laparoscopy, okay? Anytime you see a pneumoperitoneum, don't think twice, start surgery. You can open him up and start your surgery. Acute gastrointestinal bleeding, we have the upper one and we have the lower one. So the upper one is defined as upper than the ligamentum infiltrates. I want to show you that. It's located in the, like on the duodenum, ligamentum infiltrates. Yes. So you can see this one here, yeah? The suspensory ligament infiltrates in the duodenum. So anytime the hemorrhage is proximal to this, we call it upper GI bleeding. Anytime the bleeding is distal to this, we call it lower GI bleeding. So upper GI bleeding originate proximal to the ligamentum infiltrates, which is the suspensory ligament of the duodenum, usually presents with hematoemesis, which means vomiting blood, or melena. I have to explain that. Why these patients have melena? What does melena mean? Melena means black stool. Absolutely. Black stool. Yeah? Blood normally is red. RBC, heme from the RBCs is red. But after being exposed to the acid of the stomach, it converts from heme to something called hematine, which is black. This hematine will be going out with the stool, making it black, or the vomit making it black. A quick real life story, that case that I diagnosed it, and practically it saved the life because of this little trick. My father was having this, like he was like, he's a diabetic, so he does not feel the pain. And he has, like, he kept telling me that he feel nauseous all the time, okay? And he kept saying that I keep feeling lightheaded, you know? Whenever you check his blood pressure, it's low. He kept checking his blood pressure, it was always low. He did multiple, like, you know, he's more than 50, so colonoscopy was done, nothing, clean. CBC, we took a look at it. He had anemia. Okay, fecal blood occult test, negative. Remember, this test is never sensitive, never specific, bad test. Why? Because at that moment, every time we checked him, at that moment he was not bleeding, which means the test was always negative when we checked him. So what happened next, that I was like far away from home, and he called me and he was like, oh, today something weird happened. I was like, what happened? He was like, I don't know. I had this overwhelming feeling like I want to vomit, and I vomited and it looked like oil. I was like, what do you mean? He was like, it looked like, I don't know, really dark. It was like coffee. And it ringed. So I was like, okay, well, sit down. I will send you an ambulance. He was like, no, I feel fine. Everything okay. So I sent him the ambulance and they took him. He was really mad at me. But by the time he made it to the hospital, they did the endoscopy and he had a profuse bleeding from his stomach from a gastric ulcer. He did not feel any pain. Why do you think he did not feel any pain? During all of this process of the ulcer, takes a lot of time. Exactly, diabetes. Why do you think? What was the cause? Yes, but what was the cause of the ulcer? This is a USMLE question. What was the cause of the ulcer? It doesn't matter what stuff. He used to take aspirin. He used to take a lot of stuff, but that is not the cause. The cause was the H. pylori. The H. pylori was positive, so we treated him for H. pylori. I changed his medication from aspirin to clopidogrel because of a previous MI history, which is the correct thing to do. Why? It's a bad idea to keep him on aspirin, guys. Absolutely. It will reduce the amount of prostaglandins, which decreases the protection of the stomach. So that's important. So, okay. That's why upper GI bleeding, they write, it's associated with peptic ulcer disease or variceal hemorrhage. It's super serious condition. It can lead to the death of the patient. Lower GI bleeding originate distal from the ligamentum infiltrates, usually presents with hematochezia, and is associated with inflammatory bowel disease like Crohn's and ulcerative colitis. Diverticulosis angiodysplasia, I will explain for you guys what is this. This is important. Internal hemorrhoid or external hemorrhoid or cancer. Guys, if the bleeding was upper, the blood will be black. If it was lower, the blood will be pink. So for the upper one, you will need to do an endoscopy. For the lower one, you need to do a colonoscopy. Now I have a tricky question. What is the only case the patient will have a lower GI bleeding, but it will be black? Lower GI bleeding, but it will be black. Nope, it's Michel diverticulum. Michel diverticulum. Nope, nope. Michel diverticulum. Michel diverticulum have gastric mucosa inside of it sometimes. So when this gastric mucosa is going to secrete the acid inside of the small intestine, it will lead to black diarrhea. This is the only case you have to know for the USMLE in which the patient has a lower GI bleeding, but it's still black. So the story will be about a child with a negative endoscopy who has black stools. Why? Michel diverticulum. Done. Okay, the last topic for today is about malabsorption syndromes. It's quite a little bit of a long topic, but yeah, we will do it today. So let's just take 6 minutes break. We'll rest up for a second, and I will then explain for you malabsorption syndrome, super high yield for the USMLE. So see you guys in 6 minutes. Okay, so let's do malabsorption. Let me see. Okay, done. So malabsorption syndrome, it's a problem in, obviously, the absorption. Mal means little, absorption means absorption. So it can cause diarrhea. Steatorrhea means fat in the stools, okay? Fat in the stools. Weight loss as well, because you are losing plenty of fat in the stool, you are unable to reabsorb nutrition. And weakness, plus vitamins and mineral deficiency. Which vitamin deficiency you might get if you are unable to absorb the fat? Any ideas? Excellent. A, D, E, and K. And you must screen for fecal fat. So there is something called the Sudan stain. The Sudan stain has been made to check for fat in the stool. It will look yellow oranges. So if you take a look here, you can see this little globules of fat. Yes, this is the Sudan stain. Yes, this is even better. This is the Sudan stain. You can see this orange fat. So here you go. Celiac disease, on the other hand, it's a subtype of it, and it goes something like this. So celiac disease, also called gluten-sensitive enteropathy, also known as the celiac sprue. It's an autoimmune mediated intolerance of the gliadin. Gliadin, what is gliadin? Gliadin is a portion of the protein gluten. So gluten is found in wheat and barley rye, and this gluten, you hear somebody like, he tells you, oh, I have this sensitivity to gluten, it's bad, and stuff like that. And we have something like this. So the patient will have the like sensitivity to gluten. It's not to the gluten himself, it's to a subunit of it called gliadin. Okay, so he has sensitivity to the gliadin, not the gluten himself, but the gliadin inside of the gluten. It's associated with the HLA DQ2 and the HLA DQ8. And these will be represented, tell me please guys, is it in the MHC class 1 or 2? Absolutely, absolutely. Okay, excellent. So it will be MHC class 2 because there is two basically letters. So it's mostly in the Northern European descent, and primal Northern European, which countries? Which country are the Northern European? They want you to know in the USMLE. Norway, Ireland, yes. So the patient is going to have this malabsorption syndrome, and basically they are going to lose, first of all, the function of the duodenum, and then the proximal jejunum. So they can have malabsorption as steatorrhea. They can have multiples vitamin deficiency A, D, E, and K. And since they have affection of their duodenum, which substance is absorbed in the duodenum, guys? Which substance can be absorbed in the duodenum? Okay, so some vitamins plus mainly iron. Iron, okay? Iron will be the main thing. So the treatment is a gluten-free diet. It's associated with dermatitis herpetiformis, and it can lead to decreased bone density. Any idea why? The decrease in the vitamin D, absolutely. And the dermatitis herpetiformis, it's basically a vascular lesion that can occur in the skin, all over the skin, and you must know why. You not must know why it occurs. Let me tell you. It's due to an IgA deposition in the dermal papilla. Okay, so there will be decreased bone density, and it's moderately increased risk of cancer, especially T-cell lymphoma. And we have established why these patients can have this T-cell lymphoma. Okay, so the deoxylase test will be abnormal. What does the deoxylase test? Why we use the deoxylase test? Well, it's for excellent. It's a sugar that is fully reabsorbed. Yes, so it's fully reabsorbed if the walls of the small intestine are intact. So it checks if the wall of the small intestine are intact. And for the celiac disease, there is multiple antibody you can check. IgA anti-tissue transglutaminase, IgA anti-indomethacins, IgA anti-deaminated glycine peptide antibody. In which patient all of these tests will be negative? Which patient with celiac disease will have a false negative test because he has another disease? Which other disease? No, patient with HIV will have B cells. He just does not have T cells. So basically, this is going to be in a patient who is IgA deficient. So it's IgA immunodeficiency or protons. So in case of IgA deficiency, if they ask you which test to do, you tell them it's the IgG test, okay, not the IgA test. So the histology will show villus atrophy, crypt hyperplasia, and intraepithelial lymphohistiocytosis. Actually, I want to show you this. So this is a bad picture, like always. So let's take a look at it here. If you take a look at the histology, you can see this blunted villi, guys. The villi should not look like this. They are quite blunted, yeah. And you can see how much lymphocyte are inside of the walls. Well, you are like, but I cannot see anything. Well, the lymphocyte here are this thing. The little dots are the lymphocyte. This is the blunting of the villi, which means it's a flat. Normally it should have like, you should be able to go down and up, but no, it's blunted. So this is celiac disease. Okay, and you can see here the microabscesses. Okay, and the next one, you can take a look here. Here is a small intestine. There is villus atrophy. There is intraepithelial lymphocytes and crypt hyperplasia. You can see when the gluten makes it in our body. Where does the gluten come from, guys? Where did we get the gluten from? Yep, wheat, absolutely. So the gluten gives something called the gliadin. and the gliadin is going to be it is going to get inside of our body, and we have the tissue transglutaminase against it. Yes. Also, we have the G, here the gliadin basically, and the deaminated gliadin, and we can have antibodies against it as well. So the antigen presenting cells are going to present the gliadin to the T cells, and the T cells are going to present it to the B cells, and the B cells are going to make all of these antibody against it to attack the tissue transglutaminase, to attack the deaminated gliadin, and to attack the endomysial gliadin. So this is the pathogenesis. So the gliadin go in, presented by antigen presenting cells to the T cells. The T cells do cross-linking with the cross-matching with the B cells, which lead to an immunoglobulin class switching, which will create us an IgAs against all of these antigens. After that, we'll have an intraepithelial lymphocyte, villus atrophy as well, which will destroy basically the function of the small intestine and will prevent the reabsorption of the deoxylase. So in these patients, what will happen to the level of deoxylase in the urine? Reduced. What about in the feces? No, in the feces it's going to be increased. Why? Think about it. If I cannot reabsorb it, where it will go? If you cannot reabsorb the deoxylase, where it will go? It will logically move into the feces. Absolutely. Yes. So the deoxylase, as you can see, try to get reabsorbed and it fails. So it goes to the feces. So it increases in the feces. The next one is lactose intolerance. It's something that everybody has, including me, but everybody says that we don't have it, including me. So how common is lactose intolerance? Is it common? Yes, it's really common. Everybody has it, everybody denies it. So mostly, is it inherited? I mean, was I born with it or I got it when I got older? Most likely. Yeah, when I got older. So, lactose intolerance. Lactase deficiency can occur. Normal appearing villi. This is super important because they will tell you about a biopsy with a normal appearing villi. Except when there is injury of the tips of the villi due to viral enteritis. So, I can be a total normal human being, but when I got older, I mean at age maybe 16, 15, I got a really bad gastroenteritis, which led to destruction of the tips of my villi, which led me to have lactose intolerance. So, osmotic diarrhea will occur. Why? Because lactose is what? It's osmotically active. It sucks water, yeah? With a decreased stool pH, because, guys, does anybody of you remember the lac aberon? Who uses the lac aberon? E. coli. Yes, where is E. coli located in our body? GIT. So the lactose, when it's present inside of the colon, the colonic bacteria is going to use its lac aberon to ferment the lactose, which is going to produce gas. And when you have a lot of gas, you will not have a lot of guests. Yep, absolutely, you will be farting. That's the idea. So it's all because of the lac aberon and that freaking E. coli. So lactose hydrogen breath test will be also positive. For lactose malabsorption, if both lactose breath hydrogen values rises 20 ppm compared to the baseline. Let me explain this test and let me explain how do we do it. The lactose hydrogen breath test. It is a little bit of a complicated test actually. So that's why I want to give you the steps, and if you know the steps, it will be much more easier for you. So the lactose hydrogen breath test goes something like this. You tell the patient, can you please inhale this? Can you please consume this glucose or lactose for me. So lactose most likely, if we want to check for the lactose, and he consumes the lactose and it goes inside of his GIT, it will be fermented, and then the hydrogen is going to be excreted into his lung. From the lung, he's going to breathe it out, which is a positive test. This is one test we can do. It's not done that often. This is done more often. What is this? You bring the patient and you tell him, okay, can you please get this urea and ingest it? Like you give him some urea capsule and you make him like swallow it. It will go to his stomach. This is for checking for what? This is different test. It's not the hydrogen breath test. It's the urea breath test. For which infectious disease are we doing it? The urea breath test. Which infectious disease do we do the urea breath test? The H. pylori, absolutely. So in that case, we give him the urea and it's going to be converted and released by the lung to ammonia. If that is the case, he has H. pylori. But this is not our test. I just told you about not to confuse it. But if we speak about the lactose, we consume it. It will go to our colon. Then it's going to become hydrogen, which will be exhaled by the lung, and it will be represented on a graph. When the hydrogen to the methionine level will be high, this is a positive sign of basically lactose intolerance. We don't test it often. It's a clinical test overall. So pancreatic insufficiency. If we have chronic pancreatitis, we can have reduction of the enzymes and the hormone produced by the pancreas. So this can be mostly due to cystic fibrosis. Can somebody tell me what is the most common infectious agent in case of cystic fibrosis patient under 20? Yep. No, under 20, not over 20. Over 20 was Pseudomonas. Under 20 was Staph aureus. So cystic fibrosis, obstructing tumor can also lead to pancreatic insufficiency, like a cancer of the head of the pancreas. They can lead to malabsorption of fat and fat-soluble vitamin, the A, D, E, and K, as well as vitamin B12. Keep in mind that patients with cystic fibrosis, they have pathologies of two organs, lung and pancreas. Yes? So there will be decrease in the duodenal bicarb and fecal elastase. Why? Because who makes the bicarb? The organ that makes the bicarb is the pancreas. Fecal elastase. Who makes the elastase? Again, the pancreas. So you need to check for elastase to check for the function of the pancreas. However, the deoxylase checks what? What does the deoxylase check? Small intestine. Yes. Okay. So, and in pancreatic insufficiency, that will be okay. So the next thing is the tropical sprue. It's somebody who traveled to the Caribbean and now comes back and he has a malabsorption syndrome. So similar finding as a celiac sprue, it affects the small bowels but responds to antibiotic, which means what is the cause? Most likely, it's actually unknown, but we believe that it's bacterial because it responds to the antibiotic. Yeah? So its causes is unknown, but seen in resident or recent visitors to the tropics. We don't know exactly what causes it, but we are pretty sure that it's a bacteria because the antibiotic works against it. So there will be decreased mucosal absorption affecting the duodenum and the jejunum, but can involve the ileum with time. So the question comes, what will happen to the deoxylase test in this case? What will happen to the deoxylase test is going to, yes, be abnormal. The deoxylase in the blood and the urine are going to reduce and they are going to be higher in the feces. So it's associated with a megaloblastic anemia due to the folate deficiency and later B12 deficiency. Folate is absorbed from the jejunum and B12 is reabsorbed in the ileum. Weevil disease, the last one. Infection by Trophorema weevili. It's an intracellular gram-positive organism. A lot of students, one of the hardest tasks for them is to be able to differentiate between Weber disease and celiac disease. The main way to differentiate between the two, that the celiac disease has the dermatitis herpetiformis because of the IgA deposition in the dermal papilla, while the Weber disease have other systemic finding like cardiac condition, arthralgia, and neuropathy. No other malabsorption syndrome going to have arthritis, cardiac finding, endocarditis, and encephalopathy. So the patient are going to test BAS positive, which stains basically glycogen. It's basically macrophages in the intestinal lamina propria are going to consume a lot of glycogen and are going to fill up the area and test BAS positive. And they will be in the mesenteric node as well. So let's take a look at the Weber disease. Intestinal biopsy. So I hope you can see all of this. There is a lot of glycogen, difficult to see. That's exactly why we use the BAS stain, okay? When you do use the BAS stain, now it's easier to see. See all of this pinkish stuff? This is glycogen, okay? So you can see it. It's filling the whole villi with glycogen because it's the macrophage ingesting them. So that's an important sign. Okay. The patient is going to have cardiac symptoms, right? Endocarditis, arthritis, arthralgia, neuropathy, encephalopathy are common. So systemic problems can occur in this patient as well. Diarrhea and steatorrhea occurs later in the disease course, most common in the older males. Guys, it's bacterial, and anytime you don't know which antibiotic to give for something that probably comes from some metrobics or something from the outside or something fishy coming from animal, which antibiotic you are going to give? Doxycycline, absolutely. For both tropical screw and Weber disease, we give doxycycline. Okay, guys? Okay, good. So today we finished 5 pages. That's good. And now I will call it off. But tomorrow is actually off. And I wanted to ask you guys to do something like this. So I will make a poll about it. But basically, I want to change Saturday class to Sunday. So I will open a poll about this right now, and we will see what we can do about it. So until then, see you guys later. Bye-bye.